Now next topic, moving on to mouth preparation in removable partial dentures. So the way we discussed about the mouth preparation in complete dentures, in the same manner there are some prerequisites which you need to keep in mind before you start with your planning and fabrication of your cast partial denture. This comes as a long answer or sometimes as a short answer also. Okay, so we'll be seeing following headings, right, starting from the introduction till what are the different types of mouth preparations which are to be done, right, the classification, summary and conclusion. Right, so if I start first, so what is mouth preparation, right? So the preparation of mouth actually is fundamental, or it is a very essential need, okay, for a successful removable partial denture. So if you are planning for a removable partial denture, that means a cast partial denture, yes, mouth preparation becomes very important, right? And moreover, it is not that mouth preparation is it's not just a single factor. There are various factors, okay, which play their role, which contribute to the philosophy of a prosthesis being successful. Okay, so now it is not only that the missing teeth should be replaced, right, but you should try to preserve as much as the amount of tissues which you can in a good and healthy state, so that it enhances the cast partial denture or a removable partial denture. So basically what I'm trying to say is mouth preparation firstly is a very important aspect of planning and fabricating a cast partial denture. Apart from that, you need to have a thorough diagnosis, case history, all data should be collected from the patient. You take the diagnostic cast, you mount them, okay, into the jaw relationship, you survey it. Based on that, you decide the pros and cons of various designs and your treatment plan, what would be the prognosis. So after doing all this work only, you can move on with fabrication of a cast partial denture. So a thorough knowledge of mouth preparation procedures is also very important, right? Now next, if I start with the definition, yes, by William L. McCracken, it is defined as mouth preparation for partial denture follow in logical sequence. That is, first you do the diagnosis, then treatment planning, and we might say that the mouth preparation begins where the treatment planning ends. Okay, so as soon as you have finalized your treatment plan, your design of your denture, the next step is your mouth preparation, right? So now if I talk about the steps in fabrication of mouth preparation, it is divided into 6 steps, right? The first step being the diagnosis and treatment planning and treating the emergency conditions. Step 2 being the oral surgical procedures or any periodontal procedures, surveying the cast and everything. Third is designing. Fourth is mouth preparation and final impression. Fifth is fabrication, and sixth is insertion. So these are the whole stepwise treatment plan for a cast partial denture according to Stewart, right? Right now what we are discussing is the fourth stage of treatment planning or steps in fabrication of your cast partial denture. Moving on to the objectives, more specifically, if I talk, firstly, you should be, or the patient should be able to facilitate the placement and removal of the prosthesis. That is the first thing. He should be able to wear and remove easily. It should restore the physiologic function, yes, because that is why the patient wants the teeth, and it should be successful in a long run. So long term success rate should also be good. When I talk about various points in the objective, this was a broader overview, but if I want to list out, so first, to establish the state of health in supporting the contagious tissues, right? So whatever the contagious tissues are there, you need to establish a state of health for those tissues. Any interferences or any obstructions which are present, which might affect your removal or wearing of the prosthesis, that should be treated. You should be aware about the acceptable occlusal plane and scheme for that patient. And lastly, you need to have an idea that how much you will alter the natural teeth, that is your abutments, so that you reach out to your exact design and treatment plan, or you can accommodate all the various components of cast partial denture, right? So this was about the introduction, definition, a broader overview of the steps, and lastly the objectives of mouth preparation. Moving on to classification. So if I want to classify, we can classify as prosthodontic procedures and non-prosthodontic procedures. Non-prosthodontic procedures are done priorly, okay. Then after completion of non-prosthodontic procedures, the second stage will be the prosthodontic procedures, okay. So when I talk about today, we are first going to discuss about non-prosthodontic procedures, and then when we understand what are the various parts and components, then we'll study the prosthodontic procedure, because majority of part will be covered in your parts, right? So how to just place that part in that specific area is only the prosthodontic procedures, but main is the non-prosthodontic procedures, which also should not be left. Okay, so this was according to one author. According to McCracken, he divided into 4 types: oral surgical preparation, conditioning of the abused and irradiated tissues, periodontal preparation, and preparation of abutment teeth. This was a very simpler one, but most probably we follow this one. We can also call this as prosthetic mouth preparation, and this you can call it as pre-prosthetic mouth preparation. Okay, so there are two: prosthodontic, non-prosthodontic, prosthetic, pre-prosthetic. Okay, so starting with first the non-prosthodontic management. As I told, we have our oral and maxillofacial surgery problems, periodontics, conservative, and orthodontics. So these 4 branches, say related, whatever the problems will be there, you will deal them first and then move on to your prosthodontic mouth preparation phase. So starting first is you treat the emergency condition. Okay, any pain, any discomfort, any caries or any restoration which is causing discomfort to the patient in terms of pain. Okay, so that should be treated first. If you see a large carious lesion, though it is asymptomatic, but if a large caries is present, yes, immediately you should adjunct and advise a proper treatment for that problem also, and treat that before you move on to your fabrication of cast partial denture. Sometimes the gingival tissues might be seen with some infection or abscess. Okay, in that case you need to do a thorough scaling, root planing, or any periodontal procedure which is required, right? So mainly emergency problems as well as the oral hygiene, these 2 things are to be considered, right? Just a second, sorry. So if I talk about oral surgical preparation, first in oral surgical preparation, what all points you need to keep in mind? So first is the extraction of the teeth, any impacted or grossly decayed teeth, removal of root stumps, right, retained dentition or root stumps, any bony prominences, tori or exostosis are present, any chances of cyst tumors, hyperplastic tissues, bony spines and knife edge ridges, alveolar bone augmentation, and tissue conditioning, right? Now most of the headings you have studied in complete dentures, the explanation remains the same. You need to do a planned extraction, okay, before the treatment of cast partial denture starts. Okay, after evaluation that which will be your abutment and which teeth are you going to use to take direct and indirect retention, right? So based on your planning, you will decide whether to extract the teeth or to save the teeth. If it is a hopeless one, yes, surely you should go for extraction. Okay, if you go with a non-strategic approach, you might end up having complications, right, that might affect your design of the prosthesis or ultimately the success of the prosthesis. So the overall treatment plan is dependent on the strategic extraction which you take. Okay, then any root stumps, okay, or impacted teeth, okay, if you see during your radiological examination or by clinical examination, so in that case you need to evaluate that condition and come to a decision making that whether you are going to extract it or what is the alternative way of dealing with that problem, right? So any residual root fragments or retained roots, all that should be extracted, right? Impacted teeth, again, yes, if the loss of individual teeth or groups of teeth may lead to sometimes extrusion, drifting, or combination of malpositioning of the remaining teeth also. So apart from your impacted teeth, if your lower molars are extracted, sometimes there are chances the upper molar might supra-erupt, right? So that should be evaluated. Okay, if possible, orthodontic repositioning of the teeth should be done, and then you can carry on with your treatment plan. Then coming up with the bony exostosis or tori, yes, a full thickness periosteal flap will be reflected, that area will be smoothened, contoured according to the requirements, and then after the healing you can proceed with the treatment. Any cyst or tumors are present, that also should be treated. Sometimes bony exostosis might be till the gingival margins, and that might complicate the maintenance of periodontal health. Okay, so that should be kept in mind. You should treat it accordingly. If the bony exostosis is more towards the gingival margin, you should reduce it in such a way that it doesn't cause any harm or problem to the abutment teeth. Okay, otherwise sometimes you might have to modify the design of the denture if you are unable to remove that tori, restricted area where you cannot remove the tori. Then in that case you will have to modify the design of your dentures, change your components here and there, and come to a efficient design which might be successful for the patient. Odontogenic cysts and tumors, I told, they should be surgically removed and treated, and then further proceed with the treatment plan. Hyperplastic tissues, plays here. That means overproduction of cells. That means the tissue overgrowth will be there, which might be fibrous, it might be inflammatory, soft, flabby, okay, like a papilloma or a papillomatous lesion. So all this should be surgically excised, and then after proper healing of the tissues, then only you can go up with your planning or fabrication of cast partial denture. Any bony spines or spicules, sharp bony points, all that should be removed. Any knife edge ridge, that should be rounded off. All this we have already discussed when we were talking about mouth preparation in CD also. It is very important that after extraction, if you are going on with the extraction, you need to close the buccal and lingual cortical plate by giving a bidigital pressure. Bidigit means pressure from both the fingers from the either side, so that you close the cortical plate properly and there is a good approximation and proper wound healing is there. So that comes moreover in a part of oral surgeon, but still if you are going on or starting or dealing with the extraction, you should keep this in mind. Alveolar bone augmentation, that means you are augmenting the bone which is already not present. In the cases of atrophic ridges or flat ridges where there is no bone available for achieving some amount of stability or retention, right? So you can use graft materials like autogenous bone graft or hydroxyapatite graft, so that you can grow that or augment that bone and achieve a proper stability and support from that area. If any abused or irradiated tissues are present, yes, again in that case the conditioning of tissues is very much important, right? You need to take care of the tissues. You might have to give tissue conditioner, let the tissue heal, let the inflammation and everything decrease, right? So conditioning of the tissues is required if there the denture bearing mucosa, the whole denture bearing area is inflamed, or if the anatomical structures like the rugae, incisive papilla are distorted, or if there is presence of any burning sensation in the ridge area, cheeks or lips area. So that also should be taken care of, okay? And usually when you see these problems of tissue conditioning, that is due to mainly ill-fitting dentures, right? If the dentures are not fitted properly, they might move or rock, and that might injure the mucosa and the supporting tissues, or due to the nutritional deficiency, endocrine imbalances, diabetes, blood disorders like blood dyscariasis or bruxism. So all these factors are the predisposing factors, you can say, that might lead to your improper or required the need of conditioning the abused and irradiated tissues. So these all can lead to damaging the tissues. Okay, whenever you encounter such problem where the tissues are not proper or they are irradiated, they are inflammatory, you need to advise the patient that wear the denture. Okay, if the denture is the problem, patient is advised that you only wear the denture when you are comfortable. Okay, when there is pain or any discomfort and the tissues are getting injured, stop wearing the denture, do a proper treatment or medication, mucosal gel or something can be given, and then you can proceed or ask the patient to wear. Okay, if that is not possible, okay, patient has to go for a function or event where the teeth are must, in that case you can apply tissue conditioner so that it gives a soothing and cushioning effect to the tissues, and then eventually when it is healed you can reline the denture. Massaging of the tissues is also advised with that ointment or mucosal gel. Okay, you can give multivitamins, high protein diet, low carbohydrate diet. All these things also might help to an extent in improving the condition of the soft tissues, right? Periodontal problems, again if we start first objectives, yes, we should have a atraumatic occlusion, right? Occlusion should be proper, there should be no trauma from occlusion, right? This we have been studying in perio. Okay, removal and control of all the problems which are deteriorating the condition of the periodontal tissues, right? You need to evaluate the bleeding on probing depth, the level of plaque, calculus, stains, all these factors or etiological factors which might affect the condition of the abutment or the remaining dentition should be evaluated, right? Elimination, or if there is any pocket present, you need to either eliminate the pocket or go with any mucogingival surgery, right? So all these things also come into importance. It's not that patient came, you took the impression, whatever the teeth were missing, you place the teeth, RPD over. No, it's like a thorough evaluation of each and everything and then coming up to a conclusion of treatment plan. If I talk about advantages of doing this, yes, if you remove the periodontal disease, because these periodontal diseases being the primary etiological factor for tooth loss or bone loss, right? If the periodontium is disease free, it provides a better environment to restore that oral cavity, right? And moreover, response of the teeth to that periodontal therapy provides an important opportunity, because we can get an idea that whatever treatment we are doing, how the oral cavity or the patient is responding to that treatment, so that you can make or come up to a proper prognosis and make a final decision whether to include the teeth in the partial denture design or not. Right? If the abutment teeth is not responding good to the periodontal treatment, you can evaluate and reconsider your design and change the design also. So that is also one more added advantage. If we talk about the periodontal diagnosis, yes, I already mentioned we'll measure the pocket depth with the periodontal probe, bleeding on probing. Yes, we can take radiographs to evaluate the various types of bone loss, any periapical lesion, endoperio lesion, right? So all that things, you can see the continuity of lamina dura, any calcified deposit is present or not, furcation is involved or not, if it is a multi-rooted teeth. So all these things can be seen in a radiograph. Ultimately, if the teeth is mobile, you can divide it according to the Miller's classification, that is grade 1, 2 and 3, correct? Then moreover, treatment planning. So firstly, what you do is you control the disease, then you decide a definitive surgery for that problem which is present, and then recall and maintenance. So in the initial disease control therapy, if you want to control the disease, what you will do? You will do scaling, root planing, extensive oral prophylaxis measures must be taken, right? So scaling, root planing, everything will come in a primary approach where you are just controlling the disease. Eventually, if you find any gross occlusal interferences or the teeth which are the group of teeth which are not periodontally sound, you can splint them, right? You can ask the patient to use a night guard if there is any bruxism, habit of bruxism on anything which might damage the periodontal tissues. Okay, so all those things can be employed before we start with the treatment of removable partial denture. Whereas when you want to do a surgery, we know that there are various mucogingival surgeries, flap surgeries, gingivectomy procedures which are done to correct the soft tissue contours, anatomy and condition, right? This is a case where gingivectomy is done, right? More of a periopart. Periodontal flap surgery, bone loss is present, you put a bone graft and then you close the tissues. After healing, you will see improved levels of bone and good condition of the tissue. So all these things also should be done, or you can consult a specialist for this also. There is something called as guided tissue regeneration, right, where you try to regenerate a tissue in a guided manner, right, based on the tissue responses. Okay, so what you do is you use different bone grafts and tissue grafts. Okay, and this technique is very much having a potential to improve the periodontal condition if it is planned and done carefully in a proper supervision, right? So guided tissue regeneration sometimes helps in improving the condition of the bone as well as the soft tissue around the teeth, right? Then periodontal plastic surgeries like mucogingival surgeries, as I told, where you can increase the depth of the vestibule, you can correct any bone deformity, you can eliminate the pockets, you can create a good zone of thickness of adequate gingiva, you can do a root coverage procedure, abnormal frenal attachments. So all the names which you know, the mucogingival surgeries, all should be added, right? And last comes the recall and maintenance. This is very important because if you don't recall and observe whether the patient is taking proper oral hygiene measures or not, then whatever you are doing is going to go in vain, right? So sometimes it might require that you need to again go for a scaling or root planing in the consecutive appointment. So that recall system should be maintained every 3 to 4 months if you after given RPD also, so that you can track the situation and act at a correct time and stop many harmful effects happening onto the abutment teeth, the bone or the soft tissues. Lastly, orthodontic procedures. Okay, suppose they are mainly done to reduce the space for the prosthetic teeth as much as possible. Okay, position the teeth in that way that it looks that the artificial teeth is occupying the space naturally, not forcefully. You can move the teeth and create the space or decrease the space. You can create a sufficient vertical height, right, so that you can place the teeth properly, and good occlusal guidance when the teeth are aligned in a proper fashion. So you can upright the teeth, tilt the teeth, straighten it, move it, everything can be done in orthodontic procedures. But usually, as far as I have seen, this option is less considered because we have good amount of design modifications which can be done to overcome the problems. Last comes the endodontic and restorative treatment. Any root canals, crowns, inlays, onlays, any kind of restoration, direct pulp capping, indirect pulp capping, everything post and core, all should be completed in the endodontic and the restorative phase. And after that you go on with your final impression. You record the impression, you send it to lab, he makes the framework, you try the framework, take the jorilation, arrange the teeth, trial and insertion. So that is how the whole process is. After you complete this endodontic restorative treatment, now next will be in the next class, the prosthodontic mouth preparation or prosthetic mouth preparation, right? So that is all, and I hope you guys have understood. It was a very easy and a simple topic, okay, but yet can be asked in exams. You need to remember what all can be corrected, so it is easy to frame and articulate a good answer, right? So I hope you guys have understood again, and still if any doubts, you can contact me on any social media platform. I would be happy to help you. Thank you so much. Take care.